I'd like to officially welcome everybody to today's Vitamin D Study Hour. And I am so happy to have Dr. Barbara Boucher here today to discuss the relationship between vitamin D and the risk of metabolic syndrome, insulin resistance, and type 2 diabetes. And two of the publications that we decided to feature for today's study hour are co-authored or authored by Dr. Boucher. And I do want to mention she's published so many other papers. She's been doing this for decades. And I did recently share another paper that she co-authored. I believe it was published last year. So if anybody wants copies of these papers, I sent links to these papers as well before the study hour. Just let me know. So a little bit about Dr. Boucher. She is retired, but she was honorary professor of metabolic medicine. She has more than 50 years of research and clinical experience. She has worked as a consulting physician in general and emergency medicine. She was a senior lecturer in diabetes and metabolic medicine, and her research since has primarily focused on vitamin D deficiency and human disease, including environmental risk factors such as beetle chewing and metabolic health. And as I mentioned, she has authored many papers, over 160 peer-reviewed publications, and she has collaborated extensively on large international cohort studies examining vitamin D, metabolic syndrome, diabetes, and cardiovascular risk across the life course. So a few notes before I hand it over. Please submit your questions for Dr. Boucher at the end to the question and answer section, and we will answer all questions that were submitted prior to the study hour today and during the study hour after Dr. Boucher's presentation. We will be recording this, and it will be posted to our YouTube and website, and I will also email the link to everybody. And of course, just a little bit about Grassroots Health and our vitamin D action study. You can join our D action study and measure your vitamin D levels at home along with other important markers and join our cohort. And by doing that, you are supporting all the work of Grassroots Health, including these study hours. And I'm going to say my thanks now. Again, email me, jen@grassrootshealth.org, with any questions, feedback, stories. Donations are always welcomed and appreciated. And I want to thank those who support us and sponsor us. And with that, I am going to hand it over to Dr. Boucher.
Thank you very much. I'm very honored to be able to join you to talk about a topic that I've worried away at for, as you've heard, many decades. The presentation arose from a particular paper in 2020, which provides the title you can see now. And I hope that what I'm going to tell you or show you will perhaps improve your confidence that getting your vitamin D supplementation adequate should reduce insulin resistance, which has a very good chance of reducing the risks of getting type 2 diabetes. Next slide, please. Next slide. Thank you. My background, how I got into all this, really goes back, as you heard, a long way. The National Health Service in Britain, set up in 1948, one of its amusements was that it forced all British medical schools to accept 12% of their students as women for the first time, and I was one of them very shortly afterwards. I did an intercalated BSc where I learned, watched people doing research and got some idea of how it worked and how people thought about it. And I also did a little project while I was doing that BSc, sexing fetal bones from white fetuses because of a forensic nasty that had come up in our area. And on the strength of that paper, published when I was still a junior student, I was invited over to the States and had a go at doing the same thing on black bones collected by Mildred Trotter, who was extremely well known for trying to identify bones after the World War. I qualified in the late 50s, picked up a few desultory prizes, and went on to do standard residencies, training jobs, and so on, including in the Clin Labs for 6 months, where I frightened myself to death trying to do emergency tests on all the patients in the hospital who were the most ill. And in those days, us juniors did all the emergency work with no technical help at all after about half a day's training. So you can imagine it was a ferocious introduction to the situation. Anyway, I survived that and went on to get the lecturer post that Jen has mentioned to you, which was an A+B, half with the academic medical unit in the university department and half in the National Health Service. And one of the things I did was go on to set up immunoassays for the first time in our medical school, which is how I got on to vitamin D, because obviously seeing patients with rickets and osteomalacia in our community, both in elders and in our dark-skinned immigrants, we saw a lot of this problem and we had to crack on with it. And one of the really challenging things about working in East London, which I did at the Royal London Hospital, was that we saw a hugely high rate of type 2 diabetes and cardiovascular disease in our immigrants from Bangladesh. I mean, their risk was 3 to 4 times as high as those of our local indigenous people. And they also were notorious for a very high risk of oropharyngeal cancer. Next slide, please. Well, and when we started measuring vitamin D status, we were totally horrified by how much trouble there was. And we, in the community, and we had a trial going on elders with vitamin D, which we were trying to measure muscle strength. And one day, during a little break over a cuppa, the occupational therapist who was working with us on that came and told me that she had just read something very interesting, that vitamin D replacement, if you have deficiency, could boost up your insulin secretion to normal. This was an amazing fact to me, and I took it on board and wondered if that problem, being so common with us, might be aggravating more features of the metabolic syndrome and diabetes itself. And I started reading around it, which was why I wrote up a paper at the end of the 1990s on whether syndrome X, which we now call metabolic syndrome, was aggravated by deficiency. And yes, virtually every abnormality of metabolic syndrome would increase or decrease according with whether you were deficient or replete. And that was very interesting information. That's how I came to write this up. At the time, the particular risk factors being investigated back in the 90s were obviously obesity, particularly central, reduced activity, eating horribly high fat intakes. And it was also suspected that various toxins in low dose in the food, particularly nitroso compounds, would increase type 2 risks. And this had been shown convincingly in animals, not just a few papers, but gigantic tomes full of these papers from meetings on it. So it was a no-brainer to say to myself, gosh, we have so much type 2 diabetes, is it all the usual reasons, or might this lack of vitamin D, which affects your islets, aggravate the risks? So next slide, please. So the overall hypothesis, therefore, was that vitamin D insufficiency would increase the risk of syndrome X, as it might be called, or metabolic syndrome, doesn't matter what you call it, the risk of type 2. So having been told about this extraordinary new bit of information from the 1980s, which it took me about 15 years before I heard it, I started looking into it, and it was quite obvious that the variables of the metabolic syndrome would be more abnormal in those who were more deficient, and that these seasonal variations in those variables matched those of vitamin D status. So I got quite interested in this. And of course, vitamin D deficiency was increasingly common globally, although it was so easy to correct, that it seemed to me worth looking into that being a risk factor for metabolic syndrome, because it would be much easier to correct than getting people onto perfect diets and with lots of exercise and at their perfect BMI. So let's have the next slide, please. This is a sidetracking eureka moment that I just can't resist. Privilege of age, I think I'll call it. It was suddenly reported in the middle of my thinking about these problems that the reason that betel chewing, which is an addictive habit followed by 10% of the world's population, 7 million people at the moment, is the reason that it causes cancer is because the addictive alkaloids in the gut, when they're acidified by your stomach, they convert into nitrosamines, which are carcinogenic. Well, I did a little bit of work on local people, on those who chewed this ghastly addictive chew. We measured their waist size. It was increased the more they chewed, and their blood glucoses were higher the more they chewed. And I was asked to talk about those aspects of betel chewing at a meeting at the International Agency for Research into Cancer, which was about to write up the work of the remarkable Professor Tony Chen, who had been looking at health screening in many hundreds of thousands of people in Taiwan, and still increasing numbers, and he was able to look at the carcinogenic risks of this habit, because in Taiwan, the men who chewed didn't add tobacco. So when I was over there we were sitting down over lunch or something, and I said to him rather nervously, does your study include any information on blood glucose? Maybe we could look at that. And he looked at me rather pityingly and said, well, of course, we're screening for the 5 commonest health problems. We've got data for all of it. So we then published a series of papers showing that the more you chewed and the longer you chewed, the higher the risk of getting not just type 2, but metabolic syndrome, hypertension, and all the other features of metabolic syndrome. And the most interesting thing was, because he had huge studies from the community with family linkage data, and their computer services are so good that they could instantly look up the risk to the never chewing descendants of these betel chewers. And rather surprisingly, but as with the nitroso compound research in animals, those who had never chewed themselves, if their parent fathers chewed, they had an increased risk. So we wrote lots of papers on that, and it was interesting. Of course, he was interested too in the vitamin D status problem, but so far as I know to this day, and I met them when they came over a year or so back, they have not managed to look at vitamin D status as an added risk factor. Wait for it. It will come. They'll do it in the end. Tony can do anything. Okay, can we move on past my diversion? Let's go back to the paper that headlines this talk. It's important to consider whether supplementation so as to get rid of deficiency does reduce insulin resistance, and whether that has the expected benefits of reducing the risks of type 2 diabetes. So that's what that paper was all about. So let's have the next slide, please. There's all sorts of evidence I shoved in that paper, quoted, and for example, we showed nearly 20 years ago now that low vitamin D status in cohorts, for example, in the one that we examined in Nita Faruhi's studies in Cambridge, the 10-year risks of metabolic syndrome were reduced the higher your baseline vitamin D status was. And that was very interesting. That's the first thing I remember seeing on it. And Nita Faruhi went on about a bit later to report another cohort that she had exactly the same finding for the risks of type 2 diabetes. So that was interesting. And others, as you see there, in 2018, there was quite a large study showing that 12 years after a decent baseline, above 75 nanomoles, your risk was reduced by 70% of getting type 2. And then, not so long ago, the EPIC cohort showed, just in passing, excuse me, that it was basically the 25-hydroxy-D was the vitamin D metabolite that was the most strongly associated with these risks. The other metabolites might be linked to a degree, but that was the important one. And one might just remember that because it comes up later as an important factor in health risks. So next slide, please. We also know that the risks of cardiovascular disease are strongly associated with those of type 2 diabetes. That's more than obvious looking at local populations. But Harold Hemsworth recognized that both conditions were associated with a diminished ability of the tissues to use insulin. In other words, he said, insensitivity to it, not just lack of it, although both factors may operate together. Now, he presented that at 3 very famous lectures at the Royal College of Physicians the year that the Second World War broke out. But it's an astonishing fact that it took 40 years for those conclusions to be accepted. Now, I like to think that was associated with the outbreak of war getting in the way of this very important fact being appreciated. Or was it just the usual lag as seen for other truisms in Britain that has a nasty habit of neglecting things? I don't know if other countries do the same. The classic example back in the 1700s was in the British Navy, where a very observant captain, James Lind, spotted that where fresh fruit had been provided, the awful rate of deaths and bleeding and disability due to acute scurvy would fall. So he did, in fact, the first randomized controlled trial ever. He filled one ship up with fresh citrus fruit and neglected another, but studied them both equally carefully. I mean, the difference in the rate of illness and death and disability was huge and immensely important for the Navy because people ill with scurvy made very bad sailors. So why did it take till 1775 before the British Navy acted on that? I wish I knew. But anyway, eventually it got acted on and even trials became accepted as respectable. Next slide, please. Now, there are various things about how vitamin D works on the tissues that affect how we look at the findings on people of their vitamin D status in relation to their health problems. For example, I mean, years ago, back in the 80s or 60s even, it was worked out that vitamin D activated in the kidneys circulated around the body and was important for bone and muscle health, fine, and regulated by calcium and parathormone. But in the last 20 years, it's been shown, and very convincingly, mostly by Martin Hewson in his department in the north of England, that all the target tissues where vitamin D appears to have important effects, they activate their vitamin D, make active calciferol in those tissues themselves, and that the rate at which they make this active vitamin D, nothing to do with parathormone, it's activated by the concentration of the circulating 25-hydroxy-D itself, which I'll call the substrate. And it's downregulated by a tissue enzyme that destroys 25D, and parathormone has absolutely nothing to do with it. Now, most health workers in my country, at least, don't seem to know about this and don't seem to appreciate how important it is for understanding data on vitamin D and health. And, you know, we've got good evidence that vitamin D status can protect you against various microbial illnesses, reduce their risks. It is important for regulating innate and particularly acquired immunity from becoming overactivity. And one of the most important things that's been shown that is cheerfully neglected in Britain at least, is the fact that if you're obese, the more obese you are, the less you are able to produce this important substrate in the liver because it stops making 25 hydroxylase, the 25 hydroxylase enzyme that does that activation. And recently it's been shown that exactly the same thing happens in diabetes. So Ekwaru's work showed that you need up to 3 times as much vitamin D orally, or to have, if you are very obese, to get a decent blood level that does any protection. And this is the same for diabetes. And another extraordinary fact that popped up, as people got bored with trying to fund trials of vitamin D, which are very expensive, of course, and it became increasingly difficult to ensure that people were taking their daily doses, although now we know that they are the most effective, they started using large bolus doses. But there's a problem. With really large boluses, they don't work. People, it took a while to find that out. One of the studies that showed this was of children with severe rickets, and they gave them these bolus doses, and their rickets was not healed. And, you know, the mechanism is now known because, of course, the body thinks that's too much vitamin D, activates your protective mechanisms. And so what you're giving in these huge doses doesn't do much good. Right. Okay. Next slide, please. So we need to know, if we want to protect communities, how long this insulin resistance increase comes to light before you are at risk of actually getting a type 2 diabetes. Well, there are a lot of good studies. In a large Japanese study, it was 10 to 20 years, people in their late 40s at baseline, before minor increases of glycemia appeared. But they did appear about 10 years before the type 2 was diagnosed. In the Whitehall study, organized by the famous Harry Keene, who was one of the nicest and most efficient researchers I've ever known, which looked at white and South Asian civil servants in the UK in early middle age, they screened them every 5 years with a glucose tolerance test. There were over 8,000 subjects. And what he did was plot the trajectories over those years for the increase in insulin resistance and then for the appearance of diabetes. Now, insulin resistance began to rise. I can't really show this here. This is not big enough, but it is there. And 20 years before it developed. But the nasty thing was that that the insulin resistance rose much faster in the South Asians than in the white subjects. Had I been there at the time, I would probably have said, for goodness sake, let's measure their vitamin D status. That may be why the South Asians are in more trouble than the whites, but nobody was thinking that way then. And I don't think that's ever been done. Never mind, one day someone might look at it. Let's have the next slide, please. So the next obvious question is, if deficiency is linked to increases in insulin resistance, will supplementation that corrects that deficiency reduce the insulin resistance? Well, yes, it will. And I would like to just mention a study from New Zealand. The ladies who organized this, Von Hurst and Curd, happened to be in England a few years after I'd retired, and they came to see me about the design of their study. They had a whole group of South Asian women who had normal glucose tolerance, but raised insulin resistance. And they thought this was something a bit unusual, and because they were all D deficient. So they thought, well, we've seen these hints that vitamin D matters for this type of problem. We want to design a study. So they came and discussed it. And I can remember as we sat there talking about it and saying, well, I wonder, can you measure D status towards the end of the study? They didn't want to because it was difficult and expensive, and I don't blame them. I don't know what I was thinking of. I thought they'd better measure it to make sure people were actually taking it and not throwing it away, as many people might do given medicines they don't know anything about. So they did measure it at the end, and the findings are fascinating. I mean, this was years ago, and they've still quoted all the time, including as recently as 3 months ago in a new study. The deficient women would reduce their insulin resistance strikingly, but only if their 25-hydroxy-D had reached above 80 nanomoles per litre for at least 6 months during their study. That's interesting, isn't it? And of course, glycemia in type 2 diabetes can be reduced by reducing insulin resistance, even if you don't change your insulin secretion. That was shown quite recently. Well, how does vitamin D reduce this increased insulin resistance? Well, there has been quite a lot of work on that. It's basically through effects of vitamin D on liver, muscle, and islets. And I was lucky enough to be able to interest Professor Po Leung in Hong Kong, who was working on various metabolic problems in those tissues, in having a look at what vitamin D did to them. And we have published 3 papers, all during my retirement, of course. I had time to do research when I was retired. What we showed was that you reduced the synthesis of triglycerides in your liver if you replace the vitamin D through all sorts of mechanisms, which I've hinted at in that little scribble down at the bottom. And they were also, these effects were protective to the islets because they would reduce the renin-angiotensin system overactivity, which helped to protect them. And we produced 3 papers between 2011 and 16 on that sort of thing, and that was really very interesting. So if we go on, can we move on? Thank you. Therefore, it would seem to me, I mean, what I've been looking for ever since we did that work is whether the rates of type 2 diabetes may fall in Finland over time, because they had a most awful problem with deficiency and began food fortification, as you probably all know, in 2003. It wasn't doing too well, so 10 years later, they doubled the fortification in food and virtually abolished deficiency in the bulk of the population, although they did supplement high-risk groups. And that they got rid of deficiency, even in, most people weren't taking supplements. So I'm waiting to see type 2 rates fall in Finland, and I keep looking. They're looking at type 1 rates, which are beginning to fall. Who knows? Keep your eyes open. It may happen for us to see before too long. People are watching. Next slide, please. What else does vitamin D do? Now, I can't point to this, can I? No, but this little slide at the top left there is work done in 1980 by Anthony Norman and others in deficiency, looking at islet function. This is the work that my occupational therapist came and told me about. Now, normally, the islets respond to a rise in your blood glucose by firstly reducing the insulin already there, and second, that's the little peak on the left at the top there, and then by increasing their actual secretion of insulin, which is the smooth sort of 5 to 10 minute bulge afterwards. And you can see that vitamin D replenishment restored your insulin responses to normal. So I did a study in our horribly deficient immigrant South Asian populations from Bangladesh. And this is the slide, the picture in the middle shows roughly what we showed. These were very deficient people. And on the left, we did glucose tolerance tests on all of them. On the left are those who were not at risk of diabetes. And in the middle here, the lowest group, those are the ones who were at risk. That's their vitamin D status, which was obviously a lot lower than the others. And then if you look at the one next to that, you can see post-supplementation that their levels did rise, but not to the normal, which is the line on the side there. This group was incredibly deficient because it was the year after the eruption of Mount Pinatubo, and deficiency across the whole world was appalling, and certainly in our immigrant Asians, it was appalling. So what I would like you to look at, though, in terms of insulin secretion, is this slide here that you can see with the two sets of lines going up from left to right. One's 30-minute C-peptide on glucose tolerance. Oh, thank you, that's nice. And the other one is just the insulin secretion. Now, yes, that you can see here it went up. Sure, here it goes up. But what the important thing to look at is that the higher your output of insulin was in the first place when you were supplemented, the better your response. And those who have very poor responses down at the bottom of these lines got very little response at all. So that would say to me, and I think to most people, that if you can reduce insulin resistance by supplementing people, then you should be able to reduce type 2 diabetes risks with the associated heart disease risks. But it would need long-term and sustained repletion to keep things right. You can't put it right one day and expect it to last 10 years. You've got to go on with it. And of course, what this slide I've just shown you here with the 30-minute responses being better, the more normal your islets were to start with, says to me that the earlier you start repletion, the better it is. So that's my view of what we need to do. Right, next slide, please. Now, people in medicine are obsessed with randomized controlled trials, and we have confirmed mechanistic effects that are not being confirmed in trials. And you've probably all seen the work published showing why trials are often so lousy. I mean, just to mention a few of them, a lot of them, because they're not like medicines, you know, it's all or none. A nutrient will produce an S-shaped curve, and if you supplement them when they're on the flat part of the curve at the top or the bottom, you can't expect much response in whatever you want to look at. And the other thing is, particularly in healthy and wealthy countries, perhaps particularly yours, America, there were too few deficient people being recruited for the analysis to be able to show anything much. I mean, when Adrian Martineau at the London, in East London, started looking at vitamin D for reducing the risk of upper respiratory tract infections, he looked at 25 trials and there was no positive results, but he suspected from one he'd done that it was there. So he went back, he got the individual data on each participant of the 25 trials and reanalyzed the data. And he found that if you looked at those who were deficient at the beginning and not those who weren't, then you could show some benefit in reduction of upper respiratory tract infections. And I hope that, like me and all my family, those of you who are now vitamin D replete, yes, you get colds, of course, but I bet you don't get as many, and you don't get as many secondary infections. I think that work was very convincing, and I'm grateful for it. There we go. Okay, the other thing, of course, is that supplementation may not reach the blood level that you need to achieve what you want to see happen. And because of these difficulties with trials, if you're going to look at trials, it would make sense to make sure that you have a baseline level to show they were deficient and levels going along, and certainly at the end, or preferably all the way through, so that you can keep adequate levels all through trials so that the benefits can be maximized for people. And I mention that because I'm going to end with the D2D reanalysis, trial reanalysis for the type 2 risk reduction, and it really matters, as you will see. Right, you probably already know, but I'm going to say it again. Right, next slide, please. I've mentioned already that obesity can increase your requirements for vitamin D to achieve a comparable level to someone who's thin. You might need 3 times as much, and that's the same for diabetes. And I don't know any trials, I mean, maybe there are some, I don't know them, where such increases have been given, and I wish that they had been done. But if there are any more done, that must be done if you want to have a chance of getting sensible, meaningful results. Even if they're negative, they've got to mean something, they've got to be correct. Okay, next slide, please. I'm now coming to the D2D trial. This trial set up in America, another of these very expensive trials with Best, Dawson Hughes and Antonius Fittas et al., showed no reduction in risk of type 2 diabetes in that trial, even though a lot of people who were deficient were being given, or who was in the study, were being given 4,000 units a day, which is quite a nice amount compared with what most trials were giving. But maybe because of all the work that was being published, and I would like to think that, and so might Bill Grant, they went back to reanalyze their findings by basal and achieved vitamin D status right through the trial. And I think this is one of the most useful reanalyses of a study that I've seen. I mean, it showed considerable humility to go back and reanalyze it like that, but just look what they found. Your type 2 risks in all these people have pre-diabetes, not actual diabetes, will reduce up to 70% if your serum 25-hydroxy-D was running at above 100 nanomoles per litre throughout the trial, which was several years long. And that only happened in the group that were taking 4,000 units a day. And the hazard ratios for type 2, if your values went above 110, was 0.49, so there was over a 50% reduction. If you got up to 125 nanomoles per litre or more, then your reduction in risk was just over 70%, just as in the other trial I mentioned a minute ago. Now, in Britain, at least, some health bodies are now acting on those findings, and I have seen advice for those with pre-diabetes and deficiency to be given 4,000 units a day. I even have a family member with early rheumatoid who's actually, being given things that lower 25-hydroxylation, whose blood levels are being measured, and she's being told to increase, her intake. Britain's learning. We might get there one day. And I have the sort of feeling that the need for vitamin D provision may eventually begin to gain traction. I would like to think so. But all those findings that I've talked about strongly suggest to me, and I hope, I'm sure they would suggest to most people, that adequate supplementation in those up as far as they've got pre-diabetes, so long as they've still got islet function, can reduce the risk of type 2. And clearly, as this risk starts 10, 20 years before the actual condition appears, then the earlier in life you correct your D status, the better. And future trials should also allow for higher needs in obesity and hypoglycemia. So next slide, please. The current situation is for D status is quite frightening, because deficiency is common globally at less than 50 nanomoles per litre. That won't do much to prevent type 2 or many other things. And the risks of being at that level can be around 50% or more in many Western countries, 80% in Eastern Europe, or even higher in very hot countries, and 10% of all Europeans in a recent study 6 years ago had severe deficiency, less than 30 nanomoles, enough to have muscle trouble and bone trouble, and I don't know what else. So we need a major paradigm shift to focus public health action onto non-bony health benefits of vitamin D. I mean, anything else is a sad reflection on our poor health education of our population and our professional population who are supposed to be looking after us. So I've said it before, any further trials must be properly designed. So let's just finish off. I think I've got one more slide, maybe. Might be two. Can I have the next one? Yes, conclusions. Repletion of deficiency reduces insulin resistance. I'm not talking about all the other conditions where it has benefits, but it has known effects on liver and muscle and islets and cells. Since obesity and diabetes reduce circulating 25D, it's no surprise that obesity is a big risk factor for type 2. And it would help if the entire population, if their increased requirements were properly met. And adequate vitamin D repletion will also protect and improve your insulin responses to hypoglycemia, provided you've still got viable islet beta cells that are responsive, as in the prediabetes. So when I look round at the frequency of this problem and the severity of the conditions associated with deficiency and how easy it would be to solve that problem, and I hope all of you are busy doing that for yourselves, as many people in Britain are beginning to do, or certainly they did during COVID, it seems to me, and I hope my view is not too biased, that not to correct deficiency of vitamin D at the population level is not just a mistake or poor care, it is actually negligent. And there might come a time when somebody starts suing somebody and saying, it's not just negligent, it's criminally negligent. Who am I to say? But you know, my gut feeling is that we might head that way one day if we're lucky. Thank you very much. I've finished.
Let's hope that you are right. And I've had the honor of having several of our other vitamin D scientists, including Dr. William Grant and Dr. Michael Hollick, who have also discussed the history of the research of vitamin D and the importance of study design and the outright negligence of the non-action.
Have they used that word? How marvelous. I thought I was being daring.
It really is. Vitamin D deficiency is so easy to prevent
Yes.
and correct. And it's we call it the lowest hanging fruit to improve overall population health. It's safe, it's inexpensive. It's been proven to be effective. You compare,
And how it works.
especially talking about type 2 diabetes, getting people to change their diet is a lot harder than getting them to take a vitamin D supplement. Um, so yes,
There is
negligent.
one other point that the Joe public in this country bought vitamin D like there was no tomorrow during COVID, and they emptied the shelves of the shops without medical agreement or approval or anything. But I've had people come and talk to me about it and say, well, I'm taking vitamin D, no problem. I take 3 a day. And I say, yes, well, how much is in them? I haven't the faintest idea. And if they
Right.
don't know, then how do they know it's enough? And I spend a lot of my time. I obviously I say yes, 4,000 units a day is said to be safe in Britain without seeing a doctor, but provided that your family is not full of kidney stone history or sarcoidosis, making you unduly sensitive to it. So, I mean, I take that precaution when I whiffle on about this to people, but I don't think our medics do.
Right, right. And to show that 4,000 IU was not enough for what percent of the population in that last study, that really is a big eye opener for how much vitamin D is actually necessary for a lot of these individuals.
Percentage with obesity and the percentage with diabetes, which can be quite high, as you know, and it's rising all the time, obesity in the Western world. I mean, if they are deficient to start with, then they will be grossly deficient. They could need, imagine, 12,000 units a day to get a normal blood level.
Hmm. Right. And I do want to make a quick note, and I'll probably add this note at the beginning when I post this, but you were referring to vitamin D serum levels in nanomoles per liter, and we usually reference them in nanograms per milliliter. So um,
So sorry.
no. It was looking at what you had in the slides. I should have considered that, but note for next time. So just to
So
mention,
everybody here knows the conversion.
yes. So, for example, 100 nanomoles per liter is equal to 40 nanograms per milliliter. You take the nanograms per milliliter and multiply by 2.5 to get nanomoles. So,
Yes.
hopefully, some of those high numbers weren't.
You've got animals, multiply by point 4, not point 4, and you've got nanograms. So it helps.
Perfect.
Okay.
And
I don't
since
have enough time for anything.
I do have some questions for you, and I'm glad that you mentioned COVID. Because the first question was, could vitamin D deficiency, combined with conditions like diabetes and high blood pressure, have created the perfect storm during the COVID-19 pandemic and contributed to higher mortality rates in minority populations?
Well, I spent many hours of my life, as did others in the field, in vitamin D, up and down the country, in various medical schools and academic institutions, trying to educate the government about this because, um, those who were obese, they're much more at risk of deficiency, and they had a much higher mortality, if you remember, from COVID. And in our country, the people who were so-called BAME, Black and Asian ethnic minority groups, had frightening mortalities from COVID, particularly if they worked in the health service, which was horrendous. They weren't being given vitamin D. And what's more, we made endless efforts to get the government to take that on board. We even had MPs working on it with us. And, it didn't happen. The real work on educating the British public didn't come from the health services or public health or the government. It came from the media. Where did I see all that? It was in newspapers reporting it. It was in women's magazines at the dentist. And I was impressed with that because when those things appeared over the next months, as I've said, the shelves in the pharmacies and the chemists, the supermarkets cleared of vitamin D. You couldn't find any. And that must have helped. Although I think what people didn't always appreciate was how much they might need to be taking. But anything
Exactly.
was better than nothing. If you look at the data from people like Michael Hollick's study of, right across America, of the status in the months before the COVID pandemic hit, I mean, the infection rate and the mortality rate were strictly related to the deficiency rates. It could have been avoided, an awful lot of it.
Yes, a lot of research showing that correlation between vitamin D serum levels and especially the severity of the COVID infection and the mortality. Yeah, and that is that it is great that there was a lot of talk about vitamin D, but where a lot of people failed, especially a lot of experts, is exactly what you mentioned. They failed to mention how much an individual might need and
So
often or
and
often.
these poor individuals, people might, and a lot of them went to ask their doctors who
Mhm.
didn't
Right. And so they're just going to say
know
400
because
IU
you
or
get
something low
half
like
an
that.
hour's half an hour's teaching on vitamins when I was a medical student. I believe it's a bit better. My daughter qualified in the late 80s and she got about half an hour on vitamins and knew nothing about it. And I do hope it's better now. It needs to be.
Yeah. Yes. Hopefully it will improve soon. All right. I have a few other questions, and I do see that we've gotten one submitted, but I'm going to just go in order here. Are there certain challenges that diabetics tend to have with vitamin D conversion pathways or genes that affect vitamin D metabolism and use? And I think that you did kind of touch on that with the
I did.
liver's job of hydroxylating, but can you just kind of review
Yes,
a little bit?
the enzyme in the liver that produces the important substrate, 25 hydroxy D, with which we assess status, quite rightly and appropriately, because it is the most important factor in how tissues are supplied with vitamin D so they can activate it inside themselves and get things right. So those people with diabetes, they can't activate it as well. I'm not sure that I know why not. I must have another look at whether that's been shown. And of course, there may be other genetic funnies about diabetes that I don't know about, that are known of or been published. I mean, they could be there. The important thing, I think, if you've got either of those conditions, and you're worried about it, if only everybody could do it, and you're taking vitamin D, just check that it's achieving a decent blood level. I mean, for me, I would go for 100 nanomoles per litre, sorry, 40 nanograms per ml.
Okay, well, and since that is the question that was submitted, what is the recommended blood level for vitamin D, and is there any additional benefit at 200 nanomoles per liter or 80 nanograms per milliliter? And I know that, at Grassroots Health, our panel of vitamin D scientists have long recommended a target vitamin D level of 40 to 60 nanograms per milliliter. Some of them, we considered extending that range to 40 to 80 nanograms per milliliter. But what is your personal recommendation? And do you think there is additional benefit over 80 nanograms per milliliter?
I have a nasty feeling that there probably isn't, but I don't know. And someone needs to look. I mean, I would expect there to be, because there's a plateau, S-shaped curves of effects of blood levels of vitamins, including D. I would expect there to be a level above which you wouldn't expect most people to get benefit from more. And there's no point in stuffing it down, if it isn't going to help. It might have bad effects, I don't know. I mean, it's quite difficult to get vitamin D toxicity. It really is quite difficult. You have to take an awful lot, and or have something like sarcoidosis and be vulnerable. And I would think that I would like to think I might have levels about 120, 140 nanomoles per litre, round about there, but not necessarily any higher, unless I find good reasons to want to go higher. I
Right.
mean, that's the best I can do.
Yeah. And I know, I have had Dr. Cicero Coimbra on and Dr. Richard Chang, and we've talked about this topic. And also, I believe it's kind of a new concept of vitamin D resistance, where you do have certain individuals who might have SNPs in their genes or polymorphisms that affect vitamin D conversion, metabolism, and use. And so those are certain things that might need to be overcome by dosing a little bit higher and achieving higher vitamin D serum levels. And
But
I know that.
not by routinely huge doses across the population. It's those people who show up as not picking up on supplementation as they should. If someone looks, they might find they're in that group. Fair enough.
Mhm.
It would
Right.
be nice to think we might get to detecting them. And until we can actually deal with Joe Public, who's deficient as routine, there's not an awful lot of hope that we'll get there.
Exactly. And it is different. There are the therapeutic uses of vitamin D, such as in the Coimbra protocol. But that's slightly different here. We're talking about the general recommendations for public health.
I'm thinking about public,
Yeah,
provision for the population.
exactly. I appreciate both, though, definitely. So the next question, we know that improving the diet can help prevent type 2 diabetes and metabolic syndrome. Can you please explain what is the relationship between diet and dietary changes and vitamin D levels, if there is one? Is it simply that there is more vitamin D provided in a healthier diet, or is there something else going on?
I'm not sure that I know all the answers on that one. I mean, if it is quite important what you eat when you take your vitamin D. I mean, people who think they'll take it when they go to bed and they haven't eaten for hours and won't eat they don't absorb as much as when they take it with a fatty meal, which is what I always tell people. Take it with your most fatty meal. I mean, if it's butter on your toast or whatever it might be, that's when you take your vitamin D. And I've had to tell any number of people it's absorbed better if you take it with fat. I'm not very well informed on this topic. Um, I mean, if you're grossly obese, it helps to get your weight down. You will get a better activation in the liver to form substrate. And look at how important substrate is. No target tissue can do its thing without adequate substrate. And that depends on, as far as I know, hepatic activation. So,
Right.
yes, that really matters.
Yeah. And I would also assume that if you're eating a poor diet, a lot of inflammatory foods, that inflammation in the body is also using up more of the vitamin D or preventing some absorption of that vitamin D. And I'm sure there's many other factors that are contributing, but that
Very
would
difficult to look at some of those, but I'm sure they're all there.
Mhm. Yes, yes. I mean, there are certainly connections between chronic inflammation and metabolic syndrome and all of that as well.
Yes.
And diet is a big factor in inflammation. Um, okay, so
And
I just have
one
one
question,
more.
we've got time.
Yeah, I have one more question that was submitted, but let me just two of the questions that were submitted are quite similar, and I'll read them both together. In the studies, were any vitamin D activators such as magnesium and zinc also supplemented? And what about adding vitamin K2 when taking higher doses of vitamin D for endothelial protection? Do you have any recommendations on any of these co-nutrients?
I've done no personal experience working on that, but I'm well aware of the fact that in order for vitamin D to work its best, as efficiently as it can, you do need to be well supplied with magnesium, not over the top, just, what you should be having, what everyone should be having in an adequate diet. And I think the same applies to vitamin K. It does matter if you've not got enough of it, your D doesn't do its effects as well as it should. So you need those things. But, until we can get enough vitamin D into the general population, it's quite difficult to flap about getting these other things right. I just
Right.
don't know how you tackle it. Unless public health decides to have a go at what's a healthy diet generally for a population, it's going to take a little time to get there.
Right, right. And every nutrient we're oh, sorry.
I'm just saying you're right, those things do matter.
Yeah, yes, of course. And there's recommended intakes for all of these nutrients, and yet I know magnesium is one of those that is also severely deficient in terms of intake in our country and likely worldwide.
Yes.
Vitamin K2, you need to be, having a lot of fermented foods in your diet, and I don't think that very many people, especially here in the US, are getting enough. And so we like to look at how all the nutrients work together as an orchestra, right? We need optimal intake of all of them. And what sets vitamin D apart, we're meant to get it from the sun, not necessarily from our food. And here we are sitting inside all day and putting sunscreen on. And so that's what makes vitamin D.
And babies with fore and aft, practically coats hanging off their heads.
Yeah. There's a fear of the sun, and we need to overcome that and its consequences that have resulted in vitamin D deficiency.
When I was first a student, people were discovering that, there was an endocrine orchestra headed by the pituitary gland, and that this was a great focus for research, which was quite useful. We need the same thing for vitamins, take it as something that needs doing overall, not just bit by bit.
Right, right. I have one last question, and it has to do with fatty liver. So, I cannot seem to get my vitamin D level up, and it is very concerning. I have type 1.5 for 11 years now. I am 59 years of age. I sunbathe when there is sunshine, and I take vitamin D around 2 to 3,000 daily, which I'm just making an insert here is likely too low. We have always watched vitamin D level in diabetes. I don't know what could be the issue. I am sure I have fatty liver, but and has been Gluten-free, any thoughts? And I think maybe just to summarize that question, because we've discussed the doses needed and all that, but could fatty liver also contribute to a lack of dose response to vitamin
Yes,
D?
of course. And what's more, if your levels are not quite right, you're more likely to have a fatty liver. And um, I would have thought from what I've presented, the published data, that if you have type 1, you're unlikely to have a perfect blood glucose 24/7 every day of the week forever. I mean, it's very, very difficult. And if you tend to have a higher sugar on and off, you need more vitamin D. So why not try increasing your 2 to 3,000 to 4,000 and make sure you're taking it with what fat you eat and see what happens to your blood level. But don't look like tomorrow. It may take weeks or some months to see a change, but it will be worth trying. That's what I do.
Yeah, right. Well, Barbara, that's it for our questions. Did you have anything that you'd like to close with? Any additional remarks that before we say goodbye?
Well, just to say that I have appreciated the work I've seen coming from your group. I think it's so nice to see a group that looks at things as acceptable to talk about and deal with, that in my country, our medical and public health people can't be bothered with. And, I think you're doing a great job and you'll get there. Public health will pick it up in the end. Keep at it. Don't weaken.
Thank you, and I plan on it for sure. I absolutely love talking about vitamin D and continuing to learn more about it. I've been with Grassroots Health for 14 years now, and there's just still so much that I do not know. And it has certainly been fun to learn from all of the world's top, most experienced vitamin D researchers, including yourself. And I really am very grateful that you joined us today. Thank you.
Thank you
I'm
for asking me. I've enjoyed it. Thank you.
I'm glad all of our technical stuff worked out today.
Okay. Good luck for the future. Bye.
Yes, thank you. You too. All right. Bye, everybody.